HTC Medical Directors. We have Dr. Doris Kwan. Hello. From the Orthopedic Hemophilia Treatment Center. Thank you so much. We have Dr. Amit Soni. Thank you, Dr. Soni. And he is the new medical director of the Center for Inherited Blood Disorders, CIBD. Welcome. Thank you, Dr. Soni. And we have Dr. Guy Young. Thank you, Dr. Young. And he is the head of the HTC at CHLA. And thank you, everybody, for joining us already. So let's go on to question 1. This first question is for you, Dr. Soni. All right, it's been about a month since our last town hall. What's going on in Southern California? I feel like it's not being reported so much these days. We flattened the curve. Our cases going down, our deaths going down, our deaths going up. How are you feeling? Are you optimistic? What's going on with your hospital? Just sort of, can you give us an overview about the situation now?
Yeah, I think from our last town hall meeting, I think unfortunately what we've seen over the last few weekends has been increasing numbers of COVID cases in Southern California, whether it's in LA County or Orange County. I know today for Orange County, just looking, we had 249 cases reported today. So that's the highest number that we've had thus far. I think what we are seeing is that the numbers are highest in those in nursing home facilities, as well as in the prisons. So I think the numbers are also going up because the testing is now more available than it was a month ago. So in taking a look at the larger picture, yes, we are having more positive cases, but it may be because we're testing more. So I know in Northern California and throughout the state of California, other things have been opened up more than in Southern California. But I think in due time, we'll start to be loosening up, hopefully, some of the restrictions in Southern California. But I know some hospitals are planning for a peak of the COVID later this month, some even next month. As far as feeling optimistic, I was just talking with my brother who's in Tennessee, and today it's my nephew's birthday, so we took him fishing. Then he took the other kids with him and went shopping. So there's definitely a light at the end of the tunnel. They're able to do a lot of the things that we're not able to do yet, but it does give me optimism that they were also in a similar situation, although we've been on lockdown probably the longest of any in the state. But I am optimistic knowing that other people are venturing out more in other parts of the country. As far as what we're seeing at our hospital at Chalk Children's, we've had, in the interim, we've had 2 cases of COVID-19. One of them is in a patient who is a status post bone marrow transplant. And the other patient is a patient who has an underlying oncology process. So we've had one patient, we did give remdesivir because we were able to get some for him. He responded well. Oh. We initially were trying to get convalescent plasma, but it was not available for that patient's particular blood type. However, the other patient with the oncological process, that patient is going to be getting the convalescent plasma.
So convalescent plasma is hard to get. You have to have a match of the blood.
Correct. So it matches your blood type. And oftentimes people that will come in to donate, you often want to use it that same day if possible. If not, it can be stored. So just for our first patient, they had a blood type that wasn't very common. So we weren't able to find a site that already had it or had donors that we were coming in that had that particular blood type. But for the second patient that we have, it is a more common blood type. So we are able to move forward with convalescent plasma.
Wow. So would that have been your first choice, the convalescent plasma, had it been a match?
Yes, for our first patient, that would have been our first choice. Um, that was because the remdesivir is really hard to get in the pediatric setting. So our research team in our infectious disease at Chalk spent a significant amount of time allocating those resources. So the convalescent plasma was our first option just because we knew the remdesivir may be harder to get, especially for pediatrics. But there are ways to get it. It just has a process that you have to go through.
Oh, wow. Does Dr. Kwan or Dr. Young, do you have anything to add to what Dr. Soni shared?
Yeah, I guess I can start by saying that now the disclaimer is I'm a very optimistic person in general. I always see things as the glass is half full. So for me, I live near the beach. I live in Hermosa Beach, and so I was very pleased that they opened the beaches last week. There are very strict rules that you can only really swim or jog or run or things like that. You're not allowed to sunbathe or gather in groups, but there were people who were sort of sitting in very small groups, and I think they were, even though they were violating the rule, the police weren't really jumping to intervene because they were really being pretty respectful. It was like, groups of 2 or 3 people, and if there was a group sitting, there was nobody anywhere near them. I mean, way more than 6 feet, more like 20 feet away. So I think people are understanding the seriousness of the situation. And even though now they've allowed people onto the beach, and even though technically they're violating the rule, they are actually trying to be pretty respectful about it. As far as at CHLA, the other optimistic thing is that we've pretty much opened our clinics full. We saw, saw at least 20 patients with hemophilia on Tuesday. I won't say who, but some of you are on the call, I see. And anyway, so yeah, we're back to full on seeing patients. I mean, if somebody really wants telehealth and we think we can do it for them, then we'll do it. But we're pretty much back to seeing patients in full. And then just the last point is that our hospital has had 4 cases of this serious condition in young children called, well, they're giving it different names now. They're calling it multi-system inflammatory syndrome of childhood. We've been consulted on a couple of those cases. Actually, I got consulted on the first case a couple of weeks ago for a child who had very abnormal blood vessels around the heart. So, that's something I think that we're going to start to see a bit more of, unfortunately, but that's kind of the story. And in LA County, actually, the cases are going down as far as I'm aware, not going up, although I did hear that Orange County did go up a bit. But, Orange County is like another country down there. So that's all from me on that.
Dr. Kwan, do you have anything to add?
So Dr. Young said that the cases, I think the absolute numbers are going down, but overall, I think the numbers are, I guess they're kind of flattening out. I am feeling optimistic. I think that things are starting to open up a little bit more. I can tell by traffic. There's just more traffic on the streets now, and even just you can see more people coming out. In terms of seeing cases, in terms of like my clinic and downtown campus with OIC or the orthopedic, there haven't been any reported cases, but UCLA and Santa Monica UCLA have had a number of cases. They've done tons of tests, like over 16,000 tests, but only about 900 are actually positive. And of the 900, I think about 225, 250 have been admitted. And then of those, there are 20 deaths. So those are statistics from UCLA and UCLA Santa Monica. So it's very serious. But at the same time, they're going in, opening up in terms of like having elective, surgeries now, but they're being very strict about who can go into the hospital. You know, I spent so much time trying to figure out how to get an outpatient testing done, ordered, you know, for the patient, in terms of just ordering it in the computer and having the patient go to the right place to get it done. It's not just going to their laboratory and getting it done. They need it to be done at a separate site and things like that. So everybody has to have a COVID test done before they go into the hospital, before they get their surgeries done. But the good news is that they're doing surgeries now, and it's opening up again.
Right. That's great. Thank you. Okay. Boy, last time my slides were going on their own. Now they're not moving at all. There we go. Okay. This is not the question. Sorry. No, that is the question. Okay. Okay. This is a huge question. It's actually directed to Dr. Kwan first. It is floating around like crazy all over social media, especially in the bleeding disorders community. And I know we addressed it last time, but there are a lot of new people this time, and it's still going crazy. It is the implications of the COVID-19 coagulopathies, the active clotting that is happening. Is this something, this is what I'm also hearing is, I have hemophilia, I'm fine, my blood doesn't clot, I don't have to worry about this. Can you just share again about?
It's sort of yes and no. So with COVID-19, especially the very serious cases where people are getting admitted and they're going into the ICU, they have a lot of things going on. And there's a lot of inflammation going on, and a lot of inflammatory factors are being released from the body. And it's not, so there's not just factor 8 and factor 9 in the body that causes hemophilia, right? There are a lot of different other clotting factors, fibrinogen, and these levels can go up. So people can have high fibrinogen levels, their D-dimers are up, their platelets might be activated, all these different things going on. So yes, you can get, and then you get this syndrome. It's like you get this lupus anticoagulant and antiphospholipid antibodies, which they actually predispose to having clots happen. So even though you may have a bleeding disorder, many of the people are on prophylaxis. So your factor levels at some time are even higher than your baseline of your severe 0 or your 10%. So if you're getting clotting factors, then you're in the normal range. And so you can actually develop clots in the wrong place. So you may have some protection, but that doesn't mean that you're completely protected. And it's kind of like, you know, where I take care of patients who are older and they say, I can never take aspirin. But, you know, the caveat to that is, yes, you can get cardiac disease. You can have heart attack. I had somebody who's severe. He's not that old. He's 50 years old. He had a full-on heart attack with elevated troponins, et cetera. And so these things can happen. You can be slightly protected because you do have a bleeding disorder and low clotting factor levels, but that doesn't completely protect you from bleeding. And so if you, in normal cases, without any bleeding disorders, when people are that sick, they give them low levels of blood thinner so that they don't form clots in like their lower extremities or clots in the wrong place. We call that anticoagulation. And this happens more for adults than it does in children. I don't know if there's prophylaxis in children, but we call it DVT or deep venous thrombosis prophylaxis for older adults or for ill people that go in just for things like pneumonia. So a 75-year-old gentleman going in for just pneumonia, you might give him this sort of anticoagulation. Certainly somebody coming in with severe COVID-19 who needs to be hospitalized would certainly get this type of prophylaxis.
Thank you.
I mean, I would just add that the short answer, I mean, Doris gave a eloquent discussion. I mean, the short answer is we don't know whether you're protected just because you have hemophilia. And then there was a question in the chat about, well, then what if I give factor, then I'm normal? And I think that, you know, there was a commentary paper that was published from one of our colleagues, a very wise Belgian colleague, and he's taken care of actually several patients with hemophilia and coronavirus in Belgium. And the long and short of it is that patients with serious enough to be hospitalized for coronavirus need to be on blood thinners because many of them do get blood clots, sometimes even in the lungs, and that really is what leads to the demise of the patients. And so definitely patients who are hospitalized need to be on blood thinners. I don't think there's any question about that. And so what can we do about the hemophilia so we don't have a double whammy for bleeding? Well, for hemophilias, we just have to try to normalize your hemophilia. And so what he's done, for example, is put patients on a continuous infusion of factor. So it's like getting the factor dripped IV into your system continuously to maintain a steady level of factor and then giving the blood thinner. So I think that's probably the right approach. Is God forbid anybody that you know ends up in the hospital, they definitely need to be on blood thinners. There's no question about that. The hemophilia alone is not really, you know, we don't know if that's protecting you or not, and it may not be. So, so blood thinners plus factor of some kind to protect from bleeding.
Actually, that goes on. Yeah. I'm sorry. Go ahead.
No, I was just going to say it has to be a balance because I'm not sure I would give a blood thinner to a hemophilia patient without putting them on some level of factor, whatever that level might be. And I think that could be very, you know, there's not going to be one single answer. Oh, it needs to be at 50%, 80%. I think you just have to, the continuous infusion actually is what we usually do for surgery. So that seems to be reasonable.
So that's for people with severe hemophilia. And actually it brings me to my next question, was directed to Dr. Young, was what about people, so last time we talked about keeping factor levels at around 80%. And so a question came in, what about people who have mild hemophilia? Should they be capped at 80% as well if they're in that situation? And what about people with VWD and if they're on some infusion product for that? Would you also treat them the same way, or people with platelet disorders?
Sure. So there's a lot there. I'm going to try to be brief about it.
Sorry.
Yeah, no, but I'll try to be brief because I know there's lots of other questions. So I think the bottom line is definitely I think patients need to be on anticoagulants if they're hospitalized with coronavirus, because the likelihood of having a bleeding complication that's serious is probably not that high. The likelihood of having a thrombotic complication that is serious and or life-threatening is high. So you definitely need to be on a blood thinner, and as Doris said, we have to do something to correct the hemophilia defect to balance out the blood thinner. So that basically the idea is this, is let's normalize the bleeding disorder. Let's normalize the hemophilia. So get your factor, giving factor to the point that you're, relatively speaking, without hemophilia, at least temporarily. And then go on a blood thinner. So this way we're treating you like everybody else. Everybody else who doesn't have hemophilia, they may have normal factor levels. With respect to mild and moderate, it gets really complicated because what we've seen in coronavirus is patients without hemophilia, in other words, they're capable of making factor VIII. We've seen patients published, you know, in the literature who've had factor VIII levels shoot way up because factor VIII is what we call an acute phase reactant. So when you're infected, a individual who's capable of making factor VIII, when they have an infection, the factor VIII level goes up. And in fact, in some patients, they've reported levels of 400%, 500%. I mean, insanely, that's 4 or 5 times normal, and that's probably playing part into the clotting. The complicated thing about mild and moderate hemophilia is that these are patients who do have the capability of producing factor VIII. And so if the body is stimulated by an infection, it's likely, especially with mild, it's likely the factor VIII level is going up, and it may be going way up. So my answer for mild and moderate is those patients should have factor VIII levels checked while they're hospitalized with coronavirus. And then depending on the level, then decisions can be made. Because it could be a mild patient who's at 10% normally, hospitalized with coronavirus, they could be at 100 or 150%, in which case clearly you wouldn't give any factor. You would just anticoagulate. So I think for mild and moderate, because we don't know where the factor VIII level is going, it has to be checked. As far as Hemlibra, somebody said Hemlibra, we mentioned this last time. So Hemlibra gives you a fairly reasonable correction into the mild hemophilia range of your hemophilia. And so if I had a patient admitted with hemophilia who was on Hemlibra, I would probably just anticoagulate them and hope the Hemlibra is sufficiently protective from bleeding. For von Willebrand disease, only if you have really like type 2 or type 3. If it's the more common type 1 von Willebrand disease, actually most likely those von Willebrand factor levels are also going way up. So if it's type 2 or type 3, I would do, well, type 2, I do some measurements. Type 3, yes, they should get replaced just like severe hemophilia patients. Somebody said, so inhibitor patients make it more complicated. Yes, very much so. And you know, I would very much hesitate to give Novo7 or FIBA to any hemophilia patient who's admitted to the hospital with coronavirus. If they're not already on Hemlibra, it's, you know, it's probably not unreasonable to consider even starting it at that point, although it's, you know, it's not usually ideal to start a medication like that when you're in a sick situation. As far
What
as
if they're, what if it's
and
like,
sorry, just one more thing. As far as Hem B with inhibitors, because I see that question here too. I mean, that gets really complicated because if you're a Hem B inhibitor patient and you have, you know, anaphylactic reaction, allergic reaction to factor IX, you're pretty much stuck with Novo7. So, gosh, I mean, in that case, yeah, I don't know. I mean, that's a tough one. I think, yes, you could go on some kind of lower dose Novo7. I'm just making this up as I go, to be honest with you, along with some anticoagulation. But the Hem B inhibitors would be really challenging.
yeah.
And just to note, you know, with von Willebrand, they make normal factor VIII, and factor VIII is an acute phase reactant, and that actually, as Dr. Young said, you know, that can go up during this time period because there's such an inflammatory state with the COVID-19 very ill patients.
That is
So
a
it would be a
shocking
Right.
statistic. I did not know that.
It's a really good idea to measure their factor VIII
Yeah.
levels.
So it sounds like it is actually quite critical for mild, moderate, all bleeding disorder patients to be in close contact with their HTC. Hopefully they're seen at an HTC if they get admitted for coronavirus, because there is a chance they could be admitted at a local hospital where people there don't know about their bleeding disorder. So
Yeah, I would say definitely just get in touch with your hematologist and have them work with the hospital that you're admitted to.
yeah.
And again, all of this really just applies to if you're admitted to the hospital. Patients who are at home with, you know, minimal symptoms, or even if you're kind of sick with it, but you're not needing to go to the hospital, this does not apply to those patients. They would not be obviously on blood thinners. And then to those patients, I would just say continue your hemophilia treatment as, you know, as you were, or, you know, obviously, you know, you can call your HTC.
What about for people with platelet disorders? We have some Glanzmans and storage pool folks on the, I'm not calling anyone out, but I'm getting chatting these questions. What would be the response for them?
Well, I think that's, you know, probably, I mean, anticoagulation works on your clotting factors, not on the platelets. So I would just say they should be, you know, anticoagulated and then monitored for bleeding, because we don't really have, you know, a good, you know, you can't really, I mean, yes, Novo7 can be used for Glanzmans, and there's other types of treatments like Amicar and things like that. But I think if you have a platelet dysfunction, I mean, the platelets get very activated in coronavirus as well as part of the clotting process. So I would say, if anything, you know, maybe those patients have some modicum of protection from the clot. So I probably would just anticoagulate them and monitor for bleeding.
But also, I think some of them may end up with a thrombocytopenia, a low platelet level too. So I think it would be case by case in this instance.
Have you been seeing thrombocytopenia in cases of coronavirus?
There has been descriptions of it
That's low
in very
platelet
serious cases. That's low platelets, yeah.
Yeah. Dr. Soni, do you have anything you want to add before we move along?
No, I think it's been very well said by my colleagues.
Dr. Soni
The
will get the
various,
first crack at the next question.
Okay.
Yeah. I'm not sure I can add much to that.
My computer is being really naughty today. All right, I'll just ask it right here. I also have my notes, thank goodness. Okay. There are parents that are deeply concerned about this new multi-system inflammatory syndrome in children, MIS-C, that seems to be associated with coronavirus. Can you tell us more about this? Does it mean that my child could get this syndrome even if they have contracted an asymptomatic case of coronavirus? And with this new development, is going back to school safe?
great questions. So I know Dr. Young has actually seen patients with this at CHLA, but I'll start with kind of a review that these patients were not initially seen by our Chinese colleagues, but really started to be noticed in the UK and then a lot in the New York area. So there's been over 100 patients in New York, many in New Jersey, Connecticut, and all throughout the country. There's been at least three fatalities from this condition in the New York area last week. Essentially, pediatric patients what they are finding are that patients will often be presenting with fever for several days, for the most part, as well as having some other organs involved. So in the States, they named it MISC for multisystem inflammatory syndrome in children. In Europe, it was called PIMS, pediatric inflammatory multisystem. But it is in patients that have primarily presented with fever, although not all, and then also presenting with either heart issues, meaning blood pressure issues. Some of them would have respiratory symptoms, but not all of them would. Some of them would have rashes as well. COVID toes was a phenomenon where the toes would become discolored. And sometimes that might be the only symptom. A lot of symptoms also are GI, where it's nausea or vomiting or diarrhea. So those would be the things that you would look for. Now, the patients would have had the infection 2 to 4 weeks prior to having these onset symptoms. And what they feel is that the immune system may have been able to fight off the infection, but the immune system still remains ramped up and still is in a pro-inflammatory state. So you get this inflammatory process that occurs, and it can mimic other pro-inflammatory conditions such as Kawasaki disease, where you have inflammation of the blood vessels in the heart, and toxic shock syndrome, where it's just acute inflammation of all the vessels in your body. So these are how these patients are typically presenting. I'll defer to Dr. Young, who's actually seen the cases, rather than me being able to review things on the internet and online and talking with colleagues.
I mean, but that was, oh, I'm sorry.
Oh, the only thing I was going to add is, when it first was being developed, not all the patients tested positive for COVID-19. So I think in the US, it is a requirement that it is positive for COVID-19, and it's within 4 weeks of prior diagnosis of having the infection.
Yeah, I guess I'll add that this is, so what's happening is this is kids who are not having the COVID, in other words, the coronavirus disease, which is what COVID stands for, they're not having what you hear about in the news, right? They can't breathe, they're, coughing and some fever, and then you're having respiratory symptoms, right? You can't breathe, your oxygen goes down. They don't have that. They actually, they've been exposed to the virus and they've been essentially infected, but without having any of the symptoms that you read about in the news. And then, as Dr. Soni stated, some weeks later, they're showing up with the symptoms he described, typically fever, rash, and red lips, red tongue, red cracked lips. And what we're finding is that when we test the patients for the coronavirus, like with the nasal swab, which is where you're looking for active virus, this negative. They didn't have that. The 4 patients we had at CHLA, none of them tested positive. But when we did the antibody test, which is testing for past infection, all of them tested positive. And the one main publication comes from Italy, and they saw 10 patients and described them in detail. And they're all quite similar. They're typically between as young as first year of life up to about 10 years of age, although there have been a couple of teenagers as well. And yeah, the symptoms are what Dr. Soni described. I won't reiterate them. It's a mixture of those kind of things. But any child with like unexplained fever that's going on for days, especially if there's a rash, you need to contact your pediatrician and start there. And the main complication is that these patients are getting aneurysms. So those are dilations or balloon-like dilations of the blood vessels that feed the heart, so coronary arteries. So these are coronary artery aneurysms, and those can be dangerous because you can get a blood clot in there, and that could cause literally a heart attack in a child, which is something we don't hear about. And so when the patients have those, they often will consult hematology to help with blood thinners. I think the thing I do want to point out, though, is that this seems like it's probably quite rare. There's no way to put a number on it yet because we're just figuring this out. But you figure in the Los Angeles metropolitan area, there's been, a few 100,000 cases, somewhere 200, 250,000 cases of coronavirus. You got to figure a lot of kids have been exposed. They must have been, and we just don't know it because they don't get sick. And yet, at our big hospital, at Children's Hospital, we've only had 4. I mean, it's horrible for the 4, although our 4 have all survived and they've all left the hospital, and only 2 had the really bad complication of the aneurysms. So yes, it's horrible for those patients, but I do want to stress for all the parents on the call that probably this is pretty rare. I imagine there's been probably at least 10,000 kids in the Los Angeles area who've been exposed and infected with this virus, and yet we have single digits in our hospital. So yes, it's serious, and yes, you got to be aware of it. And yes, if your child has any of those symptoms, definitely call your pediatrician right away. But probably this is pretty uncommon.
And so what about school in the fall? As a
Well,
pediatrician, what do you think?
Yeah, I mean, that raises like a dozen other questions. I mean,
Okay.
and including, public health issues and things like public health issues and education issues. I can only offer my opinion. This is my personal opinion. I have a 17-year-old, so he'll be a senior starting next year, and I have another kid in college. I think that I think there's so much benefit for kids going to school, not to mention parents then being able to go to work. And of course, young kids, they learn by being in those groups and coloring and doing math. It's not as easy to teach a 4, 5, 6, 7, 8-year-old, online. So it's just my personal opinion. I know there's a lot of strong opinions about what we should do with coronavirus, but I think that we need to open the schools in the fall. However, we need to put every possible step in place to help prevent the spread of infection, not so much because kids are getting sick, they're not, but for the teachers who may be older and for the parents and grandparents that the kids may be coming into contact with. And I think that has to be a school by school basis. I mean, some schools may not have the ability to, spread the people around or to do sort of spread schedules. And I think it really depends on the school. Is it a elementary school? Is it a high school? How big is it? How many students? Can you space things out? I think that everything needs to be done. And I think, yeah, kids should wear masks. I mean, to the extent possible for most of the day. So just doing as much as possible to prevent the spread of infection once school opens. But my personal opinion is I'd like to see the schools open. But I know it's a hot button issue.
But it's difficult. I mean, I don't have a child that's in school, but I think it's difficult because, as you're saying, the kids are asymptomatic. So they can give it to their teacher or vice versa. And then they come home, they give it to their parents who, you know, so it's just sort of the snowball effect.
Yeah, I mean, there's the effect on the children not getting a proper education if they're not in school. There's the effect on the parents.
I totally agree with that piece of it.
Yeah.
And maybe for the school kids, they are not as affected. They're more asymptomatic. But college, you know, these are adults, and they're more likely to have, you know, a bigger inflammatory reaction.
Yeah, it's all I can say is that the school issues is really complicated. I think that for K through 12 school, as much as possible, we should try to have the schools open with every possible thing that can be done to prevent spread of infection, masks and distancing as much as possible, and changing the schedules. I mean, you know, maybe the school day should be longer and have half the kids come in the morning and half the kids come in the, you know, early afternoon. I mean, I don't know. I'm not, you know, familiar enough with what the schools can do, but my point is to, you know, if you're a parent and you're, you know, talking to your school board and, you know, I mean, you know, tell them what you think and how you feel and how comfortable you feel. But I think, you know, because, you know, we talked earlier about a vaccine. I mean, yeah, things are moving quickly and there's a lot of optimism, but I mean, realistically, even if there's a vaccine approved in January, which would be shockingly fast, although they are saying it's possible. I mean, think about how long it's going to take to just give the 50 million school kids in this country. You know, it's not going to be like, you know, a week or two that everybody can get vaccinated. I mean, it's probably going to may take 2 or 3 months, although I know they're getting the military involved to try to operationalize something like that. But still, for the fall session of school, there's not going to be a vaccine, that's for sure. And
Yeah.
you know,
No.
Yeah, I would just to reiterate that, you know, now we're able to identify some of the signs and symptoms that may have been missed earlier. So again, if your child is having fever for several days, call your pediatrician. A lot of times we will say it's a, you know, thinking it's a particular virus, but at this day and age, it's best to be cautious and go ahead and call the pediatrician earlier than you normally would, especially for fevers.
Thank you. Actually, this goes on to my next slide, which is for, whose turn is it? Dr. Kwan. So a month ago, all we did was talk about breathing and lung issues. It seems like all of a sudden, and I don't know why, there's all these new additional symptoms that we should look out for. So if you could just speak to that quickly, because we're a little bit running out of time.
I think
and also,
we talked about breathing. So sorry, go on. Yeah,
we talked about breathing, but it seems like now there's all these new weird symptoms that come out. So when do we go to the ER? And also, is the flu season over? Like, we shouldn't say, oh, I have a fever, maybe it's the flu, which is what we were thinking a couple months ago. But if we have a fever, is it probably coronavirus or?
Looking back at all the cases that have been tested so far, you know, UCLA, like I said, has done 16,000 or more tests, and only 800, 900 are positive. So we are clearly testing a lot, and not that many of them are positive. What are some of the symptoms? And you mentioned last time we talked mostly about breathing, because that's where a lot of the difficulty breathing, you get intubated on the ventilator, et cetera. So I think that was sort of the focus. But it's not just breathing. 90% of the people who actually get corona, more than 90%, they all get fever. So that's actually the biggest thing. And that's where, I mean, we're doing it. I'm sure other places are doing it. They're screening people for fevers when they go into the clinic or a health-related place. UCLA does it. We do it. I'm sure other places do it. Those are the most common: fevers, coughing, and it's usually a dry cough, but it can be productive too. But coughing, chills, sore throat, some of the other things. These are some weird ones, which I actually haven't read a lot about. It is loss of taste and smell at some point. And
Right.
so that you suddenly get this loss of taste and smell. The other things are GI symptoms: nausea, vomiting, diarrhea is another one. About 25% of the people present with those symptoms. Headaches, fatigue, body ache. And that's what makes it so hard, because the first symptoms may not be as severe, but then they continue on. And that's what makes coronavirus so painful, is that these symptoms go on for a long time. You know, the flu might go on for 2 or 3 days, or you might feel it for a week. The coronavirus, and you get the infection, a more severe infection, can go on for 2 up to 3 weeks. And so that's what makes it so difficult. I'm not sure when you should go to the ER. I mean, I think that is individual, but when you start feeling really short of breath, or you get chest pain and you find it really difficult to breathe, I think that's when you have to be very concerned. Sometimes it's hard. If you have a history of asthma, you should definitely go in earlier rather than later when you really feel like you can't breathe, but go in earlier. And so, yeah, I think it still can be the flu. It can be the cold. But if you wait 24 hours and your symptoms get better, then it's less likely that it's going to be coronavirus.
Okay. And I do want to reiterate, for people who do live in LA County, there is free and available testing. You do not have to have any symptoms at all. I'm sorry, I don't know what the other counties are doing. I just posted the link on our Facebook page if anyone wants to check it out. So you can get tested in LA County.
Michelle, Riverside, there's free testing too.
Oh, okay, great. Thank you.
Yeah, when you go
Oh,
to
San
the
Bernardino
site,
too, someone just posted.
Right, you can go to the site and say whether or not you have symptoms or don't have symptoms, and then it pulls down to another tab to make an appointment to actually get tested, so that you're not there with 100 other people.
That's great. Can I get the next slide, Michelle? Thank you. Dr. Young, I know you kind of, you did touch on this. There are a lot of people out there on Hemlibra, and I actually heard this in another webinar. I won't say which foundation, but somebody mentioned that there is a possibility that you could be at a higher risk for clotting if you're on Hemlibra and you do contract coronavirus. So is this actually true in your opinion, and how should, again, these labs be monitored? Then we have someone, I think he's on, who is actually on fitusiran. So those non-factor replacement products, will they affect the lab values that might have to be drawn if someone is hospitalized for corona? And then I think you already touched upon this answer. Should I receive factor replacement prophy if I am also on Hemlibra?
Sorry, I'm going to turn the lights on. Here's how dark it got. Okay, so first of all, yeah, I mean, if you're on Hemlibra, I touched on this earlier, I think that you can just simply continue with your therapy, and then if you're hospitalized, get anticoagulated. I don't think you'd have to give any extra factor, but you know, that's, again, a lot of this is just is pure opinion. There's no data here, but that's what I would do. Yes, you definitely need, you know, this is where it's important to have your hematologist involved, because they can then work with the hospital where you're admitted to make sure that they're not using a test, you know, the PTT test, which is being used routinely in patients on coronavirus to check their coagulation system. But if you're on Hemlibra, it's going to be normal. So regardless, is going to be normal. Even if you have a problem with your coagulation system, it'll be read as falsely normal. So just, you know, whoever's taking care of the patient must be aware that that test cannot be used to guide any sort of treatment or to determine any sort of response. I mean, thankfully, that test is not super important in monitoring for coronavirus. So I think doing without it is definitely not a problem. If for some reason somebody thinks, oh, hemophilia, okay, yeah, I better measure a factor VIII level, or if they want to measure factor VIII levels, they will be falsely elevated in somebody on Hemlibra. So even if your level's 0 or 1 or 2, it's going to come back 250, 300, 400, and that might freak people out because now they're worried, oh my God, you have a very serious situation with the coronavirus. So it's important to know that the PTT test is going to be normal and your factor VIII test is going to be very elevated, but falsely elevated. It's not a real elevation. And so that's, I think, what's important to know for the people who are on Hemlibra if they get hospitalized. And again, communicate with your hematologist. Now, for patients who may be on fituzaran, which is only available as part of a clinical trial, but we do have patients on fituzaran, that is not true. The laboratory tests can be measured, and they can be measured accurately. The only one that cannot be measured accurately is really what fituzaran is affecting, which is a protein called antithrombin, which is another protein involved in preventing excessive blood clotting. I don't know that. I mean, certainly it's not routine for a coronavirus patient to have an antithrombin test done. That is not a common. I mean, most people wouldn't even know what to test. But if somebody does do that, the antithrombin level is going to be very low because that's actually the way that fituzaran works. And the last bit, yeah, I wouldn't give factor replacement for anybody on fituzaran or on Hemlibra if they're hospitalized with COVID. And just get the anticoagulation and rely on fituzaran and Hemlibra to prevent bleeding.
Quick question. Is the TEG test accurate when on Hemlibra?
Actually, there's a paper that was published out of Italy, I think, where they did look at the TEG as a marker of how bad the clotting is, but the results were kind of all over the place. And so I don't think it's really, and most hospitals don't really even have this test. So I don't think anybody's typically going to be doing these in a coronavirus patient. As far as the TEG, well, it's kind of like the PTT test. So if you're on emicizumab, you'll have a normal TEG, as opposed to if you're not on if you have hemophilia and you're not on emicizumab, your TEG will be abnormal. So emicizumab does normalize the TEG, so it wouldn't be accurate.
Okay, great. Okay, next question is for Dr. Soni, and you have a string of questions, so I kind of just put together a whole bunch of random questions we got when people registered. Is this a bad time to change my factor product? Does blood type O have a lower risk of COVID-19? Can COVID-19 raise or change factor levels or VWD levels? And have there been any children with bleeding disorders diagnosed with COVID-19? Sorry, I was hoping it would be yes, no kind of answer.
Is it a bad time to change factor products? At this point, we're not recommending for our patients to change, although we've had some patients during this time change factor products. So we have some families that do want to change, so we've gone along with those wishes. Does blood type O have lower risk for COVID-19? I have not read anything about that being true. Can COVID-19 raise or change factor levels or von Willebrand disease levels? So I think Dr. Young had alluded to that earlier, especially for the milds. The factor VIII can be elevated as an acute phase reactant. Have there been any children with hemophilia bleeding disorders diagnosed with COVID-19? There have been, and I think Dr. Young alluded to that as well. We haven't had any at our center yet. And we're hopefully not going to have any, but yes, as Dr. Young had mentioned, there have been in our international colleagues.
Great, thank you. The next question is for Dr. Kwan. Which corona test is more accurate? The test in the nose? It used to say the painful nose test. So there's been some debate about that, mouth or nose. I want to go on vacation. I want to get on a flight. Having a fight at home. What do you recommend?
So if there are different tests. So the one that you're alluding to that is painful is what we call the nasopharyngeal, and this is really awful, I'm sorry, but you put the thing way into the back and you get a sample because it's the virus, there's a good concentration of virus in that posterior nasopharynx, and that's why they go back there to get a good sample. Because if you don't get a good sample, you can end up with a false negative, right? So the testing, and what they're doing there is they're doing what we call a PCR test, a polymerase chain reaction, which is a very sensitive test. It's one of the most sensitive tests to look for active virus. So you have an active infection. But then once you go or finish and your body gets rid of the infection, then your body, in order to fight the infection, makes antibodies, and there are different antibodies that get made. There's one wave of antibodies early on, and then a second wave of antibodies, which most people are familiar with, are IgG antibodies. And you can get tested for those, but those tests aren't quite as accurate, and it depends on which test you're using. And because there's a rapid test apparently that initially people were starting to use, and now I think there was an article I read on it that it's not that accurate now. There's a high false negative rate. So in my mind, the more accurate one for an active infection is using that nasal swab, and that's the one that's being recommended for admission. So people get that PCR nasal swab test before they go into the hospital. The second part of your question has to do with flights. I think with the middle seats, I remember, Casey, we had this short little discussion about all your middle seats being taken. The planes are trying to distance the people, and I think it's your own comfort level. I personally might take a flight as long as it's not very long. I'm wearing a mask and everybody else in the plane is wearing a mask. I might go ahead and do it. But if you're asking me about an international flight where I'm going to be stuck on the plane for 16 hours, I'm not sure I would want to do that. You know, actually, it was interesting. One of the airlines is offering coronavirus testing through that rapid test before you get on the plane.
Well,
I mean,
like
a little too late. A little too late to do it then. Are they not going to let somebody on the plane? I mean, that doesn't make sense.
I was like, that's really weird, but that's what somebody told me.
Well, I have a flight to I'm giving a talk at the Alaska Hemophilia Treatment Center on June 24th, and apparently that's still on. So that'll be my next flight. I'll be
wow,
like 5 weeks. So I haven't heard that that's canceled yet, although it wouldn't surprise me if it is. But so anyway, I'll wear a mask. I mean, the airlines are requiring it, but I'll wear a mask. I'll bring my Clorox wipes, and you know, I normally don't talk to people on airplanes.
You might be fine.
Sorry?
If it's not a very full flight, you might be fine.
And don't use the bathroom.
Well, it's a 6-hour flight. That's going to be.
Well, I do have a question though about that nasal thing that they stick way up your nose. And for people who have relatively uncontrolled bleeding disorders, maybe like Landsman's, is that something that they can refuse? Because
Landsman's, I wouldn't do it.
Do not go near my nose, people.
Yeah, I would just do you can do it through on the throat, which is safer. It's not quite as accurate. Actually, I just found out today from my hospital. I had a meeting with the lab because I'm the director of the COAG lab. But the head of the lab was there, and we were talking about these tests. And he said what they found in our hospital is if you do a combination of a nostril swab, so not the deep nasal scrubbing the brain swab, but you just go into the nostril, and you then also do the oral, right? So you go into the throat and you go into the nostril. They're finding that that's just as accurate as doing the deep nasal swab. But
thank you. That's very helpful. Thank you. Okay, next.
I know there was a question if a parent refused to, particularly at Chalk, about the nasal swab. I was just trying to pull up on my email what that protocol is, but I know they do have, I think if the suspicion is high that you might have COVID-19 and you refuse the testing, then I think we would then just do the full garb and assume that you're positive to protect all the other staff. I'll have to look up the email, but I know there is a process. I just don't remember it offhand if someone did refuse the testing.
Great, thank you. Okay, getting close to the end. Yeah.
That's the real reason to do the testing of the patient, is so that they know how to protect themselves.
Yeah.
Because if you test negative, then they'll just wear the mask. But if you are positive, they have to isolate you from everybody else.
So now that we have this free test available, should we go get tested?
Just to clarify, yes, if
yeah.
it is a Glanzmann's patient, yes, I would not do the testing to you. You will have hematology support in not doing a nasal testing for a Glanzmann.
Thank you. Now that the test is available and free, should we all go out and get tested? Or, oops, back. This is for Dr. Young. Herd immunity, what the heck does that mean? I think I asked that on the last one. And when are these bleeding disorder clinical trials going to go open again?
Yeah, so herd immunity basically means that if you think about, the human community as a herd, like a herd of cows, herd immunity means that the human race, or not human race, that the community of humans has enough immunity as a herd that we could protect, those people who cannot, get a vaccine. It's generally referred to vaccines, but it can be due to infection as well. So essentially, for a virus to spread, it needs to have hosts that can spread it, right? A virus is not really a living organism. It has to be inside a host. Yes, it can live on a surface for a short time, but generally just a short time. So really what we're talking about here is having enough people who are immune to COVID-19 or any virus that it makes it unlikely that others are going to get the infection. And it really relates to, the percentage of, people who have to be immune to prevent the infection from spreading through a community depends on how contagious a virus is. So on one extreme, measles, for example, is extraordinarily contagious. You just have to be in the same room as somebody. You could be 20 feet away, and if you aren't immune, you're going to get the measles. It's a very contagious disease. So for that one, the infectious disease community societies basically say that we need at least 95% of the people to be immune. So with respect to measles, that means we need 95% of kids to get the measles vaccine. And keep in mind, some kids can't get it because it's a live vaccine. And if you're immune suppressed, if you have cancer, if you've got an immune disease, if you're on other medications, you may not be able to get it. So if we have 95% of the population that has been infected, so few people not infected, immune. So few people are not immune that it's hard to actually spread the disease. For coronavirus, we don't know what the level of immunity is. If it's, let's say, right now their estimate is that in Los Angeles County, about 7% of people have been exposed to the virus and have antibodies based on a study done at USC. That's nowhere near enough. That means 93% are not immune. No one knows what the number is for coronavirus. It is pretty contagious, so I'm guessing it's going to be, upwards of 70, 80, 85% before we get there. So that's going to take a long time. And once we have a vaccine, if everybody gets vaccinated, or if everybody who can get vaccinated does, then we'll have herd immunity. So herd immunity is a way that the community protects spreading of infectious diseases by having most of the people immune, whether by having had the disease or by having been vaccinated. bleeding disorder clinical trials, that's really, there's two layers there. One is it's institution by institution. So at CHLA, we've been given permission to continue with interventional trials that are ongoing. And as of June 1st, we have permission to resume new trials as well. So we'll be able to, by 2 weeks from today, or 2 weeks from, about 2 weeks from now, we will be open for all of our hemophilia clinical trials. Not every institution is like that, so you'll have to check with your institution if you're interested. The other layer, though, is the sponsor. So some of the companies that are sponsoring the trials, if they're ready to open a trial, they may hold off for a little while. They may push it back just to protect themselves and for liability. So I think if you're interested in a trial, check with your center, see what trials you might be eligible for, and find out if they can enroll patients.
Okay.
We can enroll patients now.
It is 8:18, so if you have to go, please jump off. I only have one question, actually two. I do want to just follow up because I'm getting a lot of questions actually right now about HIV and coronavirus. Is it possible for you just to quickly address the greater risk, if any? People are wondering, is there a greater risk if you have HIV? And okay, there was another question on that. I can't find it.
I'll let Doris address that one.
Is COVID similar to HIV in the way it affects the immune system? That was the part 2 of the HIV question.
Well,
I don't know.
I'm not sure what. I think that if you're immune suppressed, that
Since
you
they're both
would
viruses.
be. I'm sorry?
Since I guess they're wondering if coronavirus suppresses the immune system similar to how HIV brings down your
that's
CD4
completely
count?
Different. Yeah.
Okay.
So
and then
the immune system goes haywire with the coronavirus, and your inflammation is like sky high if you have a really bad infection. But in terms of, I think that if you are immune suppressed, that you would be at higher risk for getting the coronavirus or having an infection with coronavirus. But the not difficulty. I think nowadays with people being on good antiretrovirals, their immune systems are much more intact. So I think from that regard, I don't think we're seeing more HIV patients coming down with coronavirus. I don't think there's an association there. And also I think because they are, quote, immune suppressed, they're probably taking more precautions. And I think that could be why maybe there's not a lot of hemophilia patients, at least in our center, that are getting infected. And it's the same thing. We're telling them to take precautions and to be safe. So I think that's playing a big role in it. First, the antiretrovirals and everybody is actually fairly well controlled, at least the population of people that I'm taking care of. And so that, I think that makes a difference.
okay.
I think if you weren't taking your medications and your T cells are down, that you would be at higher risk.
Okay. Thank you.
But I also
all right.
would tell them to take more precautions.
Okay. Take more immune precautions. Got it.
Well, wear the mask, do the distancing. I mean, it's the droplets, right? So if somebody's speaking to you and they're not wearing a mask, I would politely ask them, please put on a mask.
Okay. All right, this is the last question of the night that we have planned. So if each of you could take a turn. I know you answered this last time. We're going to ask again since it's been a month. What treatment is impressing you these days? And sort of a little bit related, if you had $1 million to invest, which treatment would it be? And then what permanent changes, if any, do you think might occur in the healthcare field as a result of COVID-19?
So I think as far as treatment plans that are impressing, I think the data that I've read and for the convalescent plasma would be an option if you're able to find the correct blood type. That is well tolerated, doesn't have as many side effects, and you're basically bringing on into your system antibodies that have worked for someone else. So that's the That would be my vote. Now, our patient did get remdesivir, and it did improve his clinical status in a matter of 12 hours. So now I'm kind of torn if I was wagering money, but I probably would still lean more towards the convalescent plasma. As far as permanent changes that may happen in the healthcare field, I think this really changes how we approach flu season as well, because there's thousands of, 65,000 people passed away from just the flu last year. So I think getting people more used to wearing masks, I think hand hygiene, doing that more frequently. I've been so conscientious of not touching my face, and my wife constantly reminded me not to touch my face as much. So I think there's a lot of personal habits that people will pick up, but I think the changes will make us more cognizant of the things that we're doing right now for COVID-19 are maybe some strategies that we should be using for flu season as well. So I wouldn't be surprised if some of this parlays over to how we treat other infectious.
Great.
Yeah, I think I would say that, I mean, nothing really other than remdesivir and the convalescent plasma. We don't have any slam dunk yet. There are companies that are working on what are called monoclonal antibodies, which is basically artificially made antibodies to target the spike protein. And they can make those pretty quickly and test pretty quickly. But I mean, it's probably still some time before they even get into clinical trials. I think the best hope here is vaccine. We heard this week, the very early results from a company called Moderna. If you're looking to invest, it's a little late. Their stock has shot up in the last month, so you might have missed the boat on that. But the results they provided seemed quite encouraging, and let's hope that that's going to work, because they believe that they'll be able to get things through the regulatory authorities and have enough. They're actually making hundreds of millions of doses, so they're really confident that this is going to work, and they're hoping that they'll have it by January. Permanent changes in the healthcare system, probably there will be more telehealth than we had before. I think that's one thing that probably we will be doing more of in the future. I think otherwise, we unfortunately have a broken healthcare system in the U.S. I mean, all these people who've lost their jobs at the same time now lost their health insurance at the worst possible time. And that's just, that's unconscionable. I mean, however your political bent is, and, clearly there's going to be people across the political spectrum on this call, but I think that, I think healthcare needs to be something that everybody has access to one way or the other. I hope that maybe, that we will have some changes in that.
Dealing with medical professionals.
That's my last comment.
So,
Thank you.
medical treatment. So if I were infected with the coronavirus and had bad disease, I think I would choose the convalescent serum or plasma over the remdesivir at this point. That would be my choice if I could choose one or the other. Keeping this short, if I had to choose which way to go, I think I would try to spend my energy making a good vaccine. So I think that's where I would head for the long term. And in terms of changes, I agree with Dr. Young with the healthcare. I'm hoping that people will look very carefully at the healthcare system, and there have to be changes. I mean, you can't lose your job and then not have healthcare. I mean, that's crazy. So, but the one thing that came out of this, I think there's more telehealth. And I know some people are not a fan of telehealth, but I think in certain situations, telehealth is a good thing, especially where people live very far from their center of care or even where doctors are. That I think that would be it setting up the infrastructure to have it. I think will I know like UCLA didn't have it and now they have it and they worked very hard to get it to work. And now that it's in place, I think it should be used more. So I think having that now is going to be a good thing.
Great. Okay. Are you guys able to stay a tiny bit longer, or how are the doctors feeling?
Tiny bit.
Yeah, I'm okay.
The doctor's
I'm
fine.
okay.
The doctor's fine. His wife wants him to watch TV with him, so I can stay for a few more minutes.
All right. What series are you watching? I'm watching Homeland, and I need to go watch episode. I'm addicted to it.
Yeah, I
Okay.
already finished Homeland. Actually, we're going backwards a little bit, watching Breaking Bad, which is really good.
Oh, Breaking Bad is so good. Okay, this question has come up a lot, and I don't know if you know the answer, but what does the latest research show as far as implications on reinfection if you've already recovered from COVID or simply just tested positive for antibodies?
The short answer is we don't know for sure.
Don't know. Yeah, I was
But-
going to say we can't answer that.
But there was a study in monkeys who have a similar immune system to humans, where they infected a group of monkeys with the coronavirus, and then they took them out of that room, and then they placed them along with other monkeys who weren't infected in a room with monkeys who were freshly infected, and the monkeys who already had the infection could not get reinfected. Whereas the monkeys that didn't have the immunity were able to get reinfected. So, I mean, the feeling is, in general, with viruses, with human viruses, and with this study, is that once you have antibodies, that you are immune for at least some period of time. It could be the immunity will go away after 5 years or 10 years, or maybe even 2 or 3 years. But I mean, I think the consensus is that, yes, you're immune at least for some time. The problem is we can't prove that until we've had more time under our belt. So you'll hear, I mean, I generally am a CNN fan, but Sanjay Gupta has kind of gone off the deep end a little bit because he's such an alarmist. So he's like, oh no, it doesn't mean anything, he said on the news one night. I'm like, well, I wouldn't say it doesn't mean anything. I mean, it means you have antibodies, and it means likely that you are protected from reinfection, but you may not be. The country that's done the most work on this is South Korea, and they have found that patients are not getting reinfected. But I think time will tell. But I would say that if you tested positive for antibodies, it's not like I'd run around without a mask or not worry about. I would still urge the same precautions, but I think that probably you are at least protected for the time being.
I agree. I think short term, but the long term may be a different answer because, again, time will tell. But I think the SARS virus, the immunity lasted only a few years, maybe 2 or 3 years or 5 years, something like that.
Yeah, I mean, that's where the vaccines will come in because, I mean, we need a vaccine
Exactly.
to go back to normal. But once we know, we're going to have, there's 120 vaccines in trials. I mean, I'm sure at least 5 or 8 or 10 will make it. And it could become, I mean, who knows? Maybe it'll be like flu vaccine. You have to get it every year. You have to get re-immunized to coronavirus. But as long as it protects you, then that's fine. It's not a big deal. But
yeah, for the short term, it's fine.
Yeah, in this early stage, we just still don't know.
Dr. Soni, do you have anything to add?
No, I think they summarized it very well.
And that's why the convalescent plasma works.
Sorry, I'm reading all the questions that are coming in, and there's so many. I feel bad about the time. It's 8:30, so I'm actually gonna wrap it up, even though there's a ton of questions. A lot of them are around school, and I think you answered that. I'm asking people for any last questions. While you're thinking, if you have any last questions that you're dying and upset that I haven't asked, can we just go to the next slide, Michelle? A lot about other proposed treatments and stuff, but I think you've been really great about answering some of your top choices for treatment. And it sounds like, at least for us, who are in Southern California and are seen at a hemophilia treatment center, that we are in good hands. So thank you, doctors, for being on top of all this. Michelle, can you go to the next slide? Just giving you one more second to ask any question, and wanting to share that on June 22nd, we are going to be doing a resume writing class. So if you are one of those unemployed and maybe you want to pivot and focus on another career, or you're launching something, please join this class. It is only limited to 25 people, and we hope that you will walk out of it with a beautiful new resume to get a new job. And then the next slide, please. Just that we will be doing a gene therapy dinner at the end of June as well, sponsored by BioMarin. And then next slide is just the big announcement that we are now launched officially. Our walk registration site is available. We are not sure yet whether this will be live or virtual, but please join us. We usually get everyone to sign up at Family Info Day, which we had to postpone. So if you do get a chance, you can sign up for our walk. Okay, here's a question. Is hyperimmunoglobulin for COVID better than convalescent plasma? And also, can you also share again, Dr. Soni, about where we can go to donate plasma if we've had positive? Is it just I have positive antibodies? I mean, that's why I got tested for antibodies, because I wanted to donate if I was positive. Is it the same also? Can people with hemophilia, this was another question, can people with bleeding disorders, hemophilia, donate plasma, or is it the same restriction? So.
Great question. So so I could tell you, when we were looking for the convalescent plasma for our patient, well, we collect at CHOC, the adult hospital next to us. St. Joe's collects. UCI, Irvine Medical Center, collects. Hoag collects. CHOC at Mission collects. So I think pretty much most of the hospitals that have patients or have a blood donation center can collect. The Red Cross also collects, and some of those hospitals will also use the Red Cross if they don't have patients currently coming in to donate. So there's a plethora of hospitals that are available to collect. As far as the as far as the IVIG, if that was what it was referring to, is the IVIG has antibodies pretty much that's normally found in plasma from a healthy donor. What the IVIG right now won't have is the antibodies for COVID-19. So by doing the convalescent plasma collection, you're really just collecting the antibodies from a patient who's had the COVID infection, who then has antibodies for COVID-19 that you can then give to a different patient. So the COVID-19 is tailored specific for the COVID-19 infection, whereas IVIG has a little bit of all the other antibodies, but probably was made probably before a lot of dissemination of the COVID-19. So the convalescent plasma would be more specific for the COVID-19 infection.
Then why would people even try to use IVIG to treat coronavirus if it doesn't have?
So we did give our patient IVIG while we were trying to get to remdesivir. So it can be used in conjunction, but if I had to choose between the two, I would go with the specific convalescent plasma. More likely than not, the patient's probably going to get both.
And just really quick.
Sorry, Michelle, but the question also asked about hyperimmune globulin, and so hyperimmune globulin, as the name implies, is like hyperimmune, right? It's like hyperactive immune, and that is a product from plasma, it's from convalescent plasma, but it's essentially, if you think about it, it's like a factor concentrate from convalescent plasma, right? So it's concentrated with antibodies against coronavirus. And there's a consortium of plasma companies, including led by CSL Behring, but including Grifols. I think Takeda's involved. There's several plasma companies that are getting together to work on this collectively. They're putting their competitive spirit aside, and they're going to be collecting in all their donation centers plasma from people who had been infected, and then essentially what the hyperimmune globulin is concentrating the antibodies for coronavirus, so you get a much more potent dose, if you will. Like I said, it's kind of like going from cryoprecipitate, which we used to treat hemophilia, to factor concentrate, right? Much more potent with factor VIII. The hyperimmune globulin is much more potent with coronavirus antibodies. But, it's going to take a while for them to, collect all this plasma and then fractionate it and then set up the portion, or, basically pulling out the portion that is the hyperimmune part of it. So that's, going to take some more months.
Okay.
Oh, thank you for that, Dr. Young. I totally misread the question, so my apologies for that.
Hey,
Oh,
if
not
you're healthy
apologizing
and
to you.
doing
I'm
well,
apologizing
go out
to
and
whoever
donate.
asked the question.
Donate blood, donate plasma. We need it. Last question of the night is really interesting. It's about wearing goggles or some protection from your eyes. I read an article about someone getting coronavirus because of getting it through your eyes. Can you kind of speak to that protection for people who may be at our higher risk?
I think that.
Go ahead, Doris.
One. No, I was just going to say healthcare workers who are very close or doing procedures with the patients usually do wear either goggles or a face shield of some sort. But from an everyday standpoint, I don't think that that's necessary. I think, again, having somebody else wear the mask, because this is where your masks are actually the biggest factor, is that if you are infected, you're not going to be passing the virus to the other person. And so it's for the other person's protection to wear the mask. I mean, there is a little bit of protection when you wear a mask, but it's mostly to prevent you from spreading the virus if you're an asymptomatic carrier to somebody else.
I think also not touching your face as much would be helpful, especially around the eyes. I know I do that all the time, and I'm more cognizant of it now. But I think not touching your face would help.
So should they wear goggles going out?
If you don't normally wear
Not part of my recommendation.
I wouldn't, because then you're gonna end up like continuously touching your eyes, which
Touching
is
it.
actually do more harm than good.
Okay.
And it might obscure your vision, so it could cause even more problems.
There's so many questions. Okay, last one. Going to the dentist. Should I go to the dentist now or wait? Because your mouth is open and,
I think, you don't want to put off routine dental care too long, but I would, for cleaning and routine dental care, I probably would put it off for a while until the numbers are a lot lower. I'm sure your dentist will take every precaution possible. They of course want to protect themselves too, but for routine dental care, I probably would hold off. Maybe a couple more months, the numbers will get much lower, and then I think it'll probably be safe.
Yeah.
Agreed. If it's an emergency, you have to go. But again, as routine stuff, I would put it off.
Thank you. Well, I have to say that this meeting takes the record as the longest Zoom call with attentive and interested participants. This is such a fascinating topic, and you three doctors, thank you so much for your time, for your commitment and support to our community. We are so blessed and lucky to have you all with us and to be able to get treatment from all of you. So thank you for your time. Everybody is saying thank you. This is, remember, thank you, applause, applause, applause. You guys are awesome and we love you, and thank you for coming again so late. It's way over time. I don't know why am I so surprised. But thank you, everyone. Also, all our community members, we love you and hope you're hanging in there. Remember to reach out if you need anything. A lot of thank yous flowing through the chats. So if you have any additional questions that you can email me and I'll try to float them over. to the doctors after and get a response to you, but remember that they're there and the emergency rooms are open. So if you need to go, please go, and always be in contact with your hemophilia treatment center. So thank you, everybody.
Bye.
Bye.